All right, good afternoon, everyone, and thanks, Kat, for the kind introduction. So the term tropes, why it's been chosen for this discussion is basically because we define it as a motif or significant recurring theme. And many of the topics that I wanted to talk about today are those which I've come across in discussions with government, medicos, politicians particularly over the last 3 years. So I'll aim quickly to just look at why we're even facing these problems in today's modern society with the reintroduction of cannabis as a medicine. And then I'll address some of them, the often touted problems such as cannabis lowering IQ, cannabis causing schizophrenia, etc. So without further ado, let's get started. So just for disclosure, I just wanted to let you know there's a list of my affiliations. So please note that I'm not paid nor have received any remuneration for the 32 talks I've done for politicians, for medicos, patients and carers over the last 3 years. All of the work I've done in this space is completely pro bono, and I am working as the chief scientist with Lucy Haslam for United in Compassion. So I've been doing quite a bit of work lobbying politicians and government. So, let's start off with this. How did we get here, where we're actually having to have discussions, symposiums, and things like that for the reintroduction of a herbal medicine which has largely been used for thousands of years? So to set the stage for the discussion, let's have a look at one of the men that's actually responsible for it all. In perhaps one of the greatest examples, I think anyway, of propaganda engineering in recent history, Harry Anslinger is largely credited with the lies and falsehoods for which cannabis is still being labelled today. Hand-selecting the best of bigotry, racism and religious fear in the strokes of pens and testimonies to Congress, he single-handedly abolished and made illegal the use of a plant that had been serving humankind for over 10 millennia. So it's said that he's bullied and coerced many in the medical profession to support his claims, with a pharmacologist, Dr. James Munch, from Temple University, who was a witness for Anslinger, testifying under oath, and I quote, that after 2 puffs on a marijuana cigarette, I was turned into a bat. I mean, obviously seems legit to me, but I would love to analyze what he was actually smoking. So after a read of this slide, I'm sure you'll agree with me, it's pretty horrifying. I mean, who in their right mind would call jazz or swing satanic music for one? Now, I don't know about you, but speaking for myself, I've partaken in far more acts of violence under the influence of alcohol than any other drug. In fact, I dare say the limits of violence that many have experienced under the influence of cannabis extend largely to smashing a packet of double-coat Tim Tams and then destroying a tub of Sara Lee ice cream over the course of about an hour. So let's now have a quick and very brief look at some of the wonders that Anslinger introduced in his propaganda campaign. They'd be hilarious if they weren't actually so effective. So, looking at this here, for the 1930s Christian and Catholic majority in the United States, a lot of these posters actually immediately struck terror into the heart of parents everywhere. So I particularly like the reference to it being used, there it is, being used as a pill up there on the right, and lots of references, of course, to hell, the devil, and sin. Now, for any God-fearing American, this was basically a mandate from on high, for to use cannabis would therefore cast doubts on one's faith. Now, this was step one in what was a very effective propaganda campaign, and at the time when you consider that of the political representative assembly in the United States, over 90% of them were actually conservative Christians and Catholics, it was a way to actually control policy as well. This is just the fun stuff. Wait until you see this next slide. So these are perhaps the favorites of Anslinger's fantasy. On the right here, we see some more positive reinforcement of the devil and religious overtones, which is good to see at least that they're continuing the continuity of the message. I also enjoy the term sex orgies. Now, I know I don't get out much these days, working largely in a lab, but I'm at a bit of a loss as to discern what other types of orgies exist, and please welcome my esteemed audience to correct me on that. But the next one there, when we look at the left-hand side is quite interesting too, looking at the use of this herb via needle. So I'm shocked to hear that obviously millions of people have been doing it wrong for all this time, and I'm sure it has nothing to do with trying to link its more dangerous use with drugs like heroin. So this, ladies and gentlemen of the jury, is why such prejudice still exists with the use of this herbal medicine, both in government and in medical training programs. And like I said before, it'd be humorous if it wasn't actually so successful. Remember the words of Winston Churchill: "A lie has traveled halfway around the world before the truth has even had a chance to put its pants on." Now, starting off the tropes, the first one I wanted to look at was IQ. So what's often been touted, particularly by medicos and government, is that it lowers IQ. So it's long been touted that it reduces human IQ and that it kills neurons. That's a key point. Now, whilst consumption of certain varieties of cannabis that have been bred to be higher in THC may indeed cause a decreased function in short-term memory, these changes are not permanent and will resolve with cessation. So obviously this is important for any students in the crowd to take notice of. Now, more importantly, however, is the recent research showing compounds within cannabis that have actually been found to be neuroprotective. In vitro and animal studies are demonstrating that certain cannabinoids in cannabis, particularly cannabidiol or CBD, may reduce damage to the brain caused by lack of blood flow or oxygen, hypoxemia, and also assist in preventing the neurological degeneration that we see in conditions such as multiple sclerosis or Alzheimer's disease. Now, whilst more research certainly needs to be conducted in human trials, these preliminary results are actually very encouraging. Now, any of you that know the significance of twin studies will get a real kick out of this publication here. Now, this recent 2 longitudinal twin studies that was conducted by Jackson and colleagues and published in the Proceedings of the National Academy of Science in 2016 found that cannabis using twins failed to show any significantly greater IQ decline relative to their abstinent siblings, which is therefore suggestive that observed declines in IQ are more attributable to familial or other environmental factors. This is another one often touted, that all cannabis gets you high, okay? Obviously, we know that dose can cause this, but compounds such as THC, tetrahydrocannabinol, delta-9 THC, generally attributed with the psychoactive effect of making the user feel high or stoned. There's also delta-8 THC and 11-hydroxy, which need to be considered here too. So narrow-leaf drug varieties that are rich in CBD and lower in THC generally don't have this effect. And what we generally find, particularly with my studies over in the United States, is that patients will tend to use CBD or lower THC strains during the day so that they're not too psycho-affected, and then during night they'll rely on strains that are a little bit higher in THC or more in CBN, cannabinol, which is actually quite sedative. So this is something we need to consider. So it's not all cannabis causing this. And I think it's also fair to say too, that not all pharmaceutical medications leave you feeling normal either. Benzos and opiates obviously have their place here. So comparing apples with apples is really important. So what about cannabis causes lung cancer? This is a really interesting one. So this particular study that I found by Hushabay, so this is a population-based control study that he conducted and his team in 2006, showed that heavy cannabis users have an equal or lower rate of lung and respiratory tract cancers than non-users, even though cannabis smoke has been proven to contain cancer-causing products of combustion. So how can this be, I hear you ask? Well, I'm glad you did. Here, likely that many of these phytochemicals that we talk about have strong anti-cancer properties, which has actually been known for quite some time. So in this paper by Munson, which was conducted in 1975, actually showed that phytocannabinoids such as delta-9 THC, delta-8 THC, and cannabinol actually retard Lewis lung cell adenocarcinoma and actually increase survival time as well. But probably one of the most interesting academics in this space is Dr. Donald Tashkin at UCLA. So he's led this research in this space, particularly with lung cancer, for decades, and he cannot actually find any direct association. He actually published this paper that you can see here in the American Thoracic Journals in 2013, suggesting that the accumulated weight of evidence implies far lower risks for pulmonary complications, including other pulmonary diseases such as emphysema, even of heavy use of cannabis compared with pulmonary consequences of things like tobacco. So long-term chronic cannabis use can increase risk of chronic bronchitis. However, because it does actually irritate the cilia of the epithelium of the lining, and it does reduce the macrophages and their alveolar activity. But it will subside generally with cessation of use. So while smoking may well need to be studied more to determine in absolute terms that it doesn't cause lung cancer, one thing I did want to bring into discussion here is that when we consider in Australia this kind of weird cult of mulling up and putting tobacco in cannabis, this obviously increases risk when it comes to the carcinogenic properties of the tobacco. And so this is often touted, that cannabis, and this is something, of course, that Dr. Teresa Taupik just talked about, that cannabis is a drug of dependence. Now, when we look at this, a lot of people saying that it's highly addictive. It's obviously an important topic, one that patients and their carers are interested in. And there's a lot of conflicting evidence when we actually look at what's in the scientific literature. But after reviewing a lot of them, sample sizes and in various studies, I found this particular paper that you see before you by Anthony, Warner and Kessler from 1994. And it surveyed about 8,000 people in the USA between the ages of 15 and 54, and it was designed purely to assess patterns of dependence. So of particular interest is that cannabis can indeed cause dependency. But let's look at things a little more closely. 24% of the study respondents with a history of dependence, that's 1 in 4, basically reported being dependent to tobacco, whereas 14% or 1 in 7 reported dependence to alcohol. Now, worthy of note here after seeing these previous statistics is that only 4% reported dependence to cannabis, 6 times less than that of tobacco. Now, we need to remember, of course, that both tobacco and alcohol are legally obtainable substances to those that meet age requirements and are not illicit substances as cannabis is. Now, many other factors also need to be considered here, such as individual variability, why the cannabis was being utilized, for example. I think it's fair to say that someone that's suffering from chronic intractable pain and they're using cannabis every day to manage that pain, that would be classified as a form of dependence. So I think that that's actually needs to be considered. Another thing also is that cannabis being an illicit substance, it's also the cheapest to obtain compared to substances such as cocaine or heroin. So you've seen this before. Teresa used this slide. So in this particular study, which was actually done in the UK, this looked at purely physical dependence. Now coffee, how many of you, show of hands, love coffee? There you go, all right. How does it feel that all of you, coffee has a higher addictive potential than cannabis? So coffee, which is not placed on the scale, comes in at 0.9%, okay? Higher than cannabis at 0.8. Yet obviously things such as tobacco and alcohol are much higher on that scale of dependence. So this now leads to the next question, which I find quite interesting. Does cannabis cause us to go on and use harder drugs? So is it a gateway drug? And the evidence here is actually quite compelling. So the idea of cannabis being a gateway drug is not new, and surprisingly, again, there's a bit of conflicting evidence in the scientific literature. So firstly, we need to consider that as cannabis is obtained from the black market, due to its current illegality, it stands to reason that other illicit drugs of a harder nature are also obtained from similar sources. So this simple association is actually potentially difficult to remove as a confounding variable. But in California, a state where legalized medical cannabis dispensaries and have had for several years, patients can access medicinal cannabis with a card from their licensed medical practitioner. And in this particular study by Ryman, in 2008, it looked just at 350 registered medical cannabis users, so no illicit patients being used here. And what they actually found is that it serves as an exit drug and not a gateway drug. So let's have a look at some of the figures they crunched. So 40% of the respondents for this study reported using cannabis as a substitute for alcohol. 26% used it as a substitute for other illicit drugs, and 66% used it as a substitution for prescription medication. Furthermore, what they found was that 65% of patients used medicinal cannabis due to the propensity for less side effects, 34% used it because it had less withdrawal effects, and a whopping 57% felt that it provided better symptom management for their specific medical condition. Now, in the interest of balance, it is important to say that this was a small study, 350 people is not that large, but it does propose a counter-argument to the traditional viewpoint. And whilst on this topic, new evidence has been shown that medicinal cannabis is associated, as Teresa alluded to, with reduced pharmaceutical opioid deaths. So the CDC, the Center for Disease Control in the United States, posted that in 2010, over 16,000 people died from pharmaceutical opioid analgesics, which equates to roughly 45 people per day, and that the opioid overdoses have quadrupled from the years 2000 to 2014. Now, in Australia, the rise of addiction has been particularly noteworthy and devastating. From 2002 to 2009, the amount of oxycodone prescribed in Australia increased by 180%. Furthermore, in the late 90s, hospitalizations due to opioid poisoning were predominantly due to heroin, but just by 2008, prescription opioids accounted for 80% of all opioid-related hospitalization. I also read recently an interesting paper by Mahuri and colleagues published in 2013, and they looked at data from 2002 to 2012, showing that the incidence of heroin initiation was 19 times higher among those who reported prior non-medical pharmaceutical opioid pain reliever use among those who did not. There was another study also by Lankenau in 2012 that suggests that young urban injection drug users interviewed between just 2008 and 2009 found an 86% had used opioid pain relievers pharmaceutically, but in a non-medical capacity. So we're obviously starting to see an interesting trend starting to emerge. So what about some uniquely Australian statistics, I hear you ask? So here they are up here, and you can see up the top total numbers of overall deaths from pharmaceuticals, illegal drugs, and alcohol from the years 2009 to 2015. So an alarming upward trend is easy to see. The second table below it shows statistics of overdose deaths just for the opioids and benzo classes. So it's easy to see that thousands of Australians have overdosed on prescription medications, but what's actually really concerning is that that's just Victorian statistics. So, and in this regard, cannabis is definitely coming to the rescue based on research that's come out over the last 3 years. So Barkhuber and colleagues published a paper in JAMA Internal Medicine in 2014, which has clearly demonstrated that state medicinal cannabis laws in the United States are associated with significantly lower state-level opioid overdose mortality rates, which lowered in year 1 by 20% and strengthened to 33% after 6 years, with a mean average of about 25%. Now, that was data was continuing to be collected, and that 33% was continuing. So such evidence supports the findings presented in those Ryman statistics earlier, and also supports that cannabis may well be an exit drug. This paper was also written by Lucas, published in Harm Reduction Journal, released in 2017, also confirms what's known as the substitution effect, and suggests that there is a growing body of evidence to support the use of cannabis as an adjunct or substitute for opioids altogether, which is particularly poignant considering the Australian Medical Association has declared this a major public health focus, both in 2015 and now again in 2017. So furthermore, and perhaps most interestingly of all, is that medicinal cannabis can show huge cost savings to our public healthcare system. I can't help but look at that wonderful Medican poster up the back there and have a chuckle. Now, in this particular study, which was done by Bradford and Bradford in 2016, it shows that between 2010 and 2013, US states that had medicinal cannabis use were shown to have a 12% lower rate for pain relief prescriptions to the US Medicaid patients over the age of 65 years of age, and that between 8 to 13% lower rates of prescription for anxiety, depression, nausea, psychosis, and sleep disturbance. So national overall reductions in the Medicare program when states implemented medicinal cannabis in the states was estimated to be approximately $165 million per year, which is obviously not an unsubstantial amount of money. So maybe it is a gateway to all to saving, or after all, to savings within our already overburdened healthcare system. Now, this is perhaps one of the most quoted problems when it comes to cannabis use. Now, one thing I just want to point out quickly is that, as you know, psychosis can be both a symptom by itself, or a feature of mental illness. It's characterized by people being unable to distinguish what's real or losing contact with reality. Now, the cause of psychosis is not fully understood, but involves a complex interplay of individual genetics, physical, environmental, and psychological factors. Cannabis is perhaps of more concern in heavy use or with younger people that are still developing neurologically. So there have been a large amount of articles proposing that cannabis can cause psychosis or schizophrenia, and of course it is a likely risk factor. However, a review article that I found, which was very interesting, by Sir and Hart in 2016, suggests that the evidence reviewed from previous studies proposed that cannabis does not in itself cause a psychosis disorder. Rather, the authors thought that the evidence led them to believe that early use and heavy use of cannabis was more likely in individuals with a vulnerability to psychosis. So more research, obviously, certainly needs to be conducted in this area for us to fully understand this relationship. And we also need to consider the quality or the variety of the cannabis that's being used, which only until very recently have been plants largely bred to be high in THC without any quality assurance testing for any additional additives. So we also need to consider the dose being taken and other pre-existing psychological or physical disease states that are present within the patient. Or what about this study done in the UK by Hickman and colleagues? It was estimated that to prevent one case of schizophrenia, approximately 2,000 young men would need to stop using cannabis. So it really does depend on what part of the statistics you look at. Or perhaps most interestingly, what we see here is that cannabis use increasing in many jurisdictions around the world since the 60s at an ever-increasing rate. What we've seen is that statistics largely on schizophrenia prevalence have remained somewhat stable at 1%. So certainly not growing at a rate that we might think is proportional to the uptake and availability. So whilst the topic may be worthy of further scientific investigation, when leading world experts like Professor Emeritus Dr. Grinspoon from a little-known place like Harvard University, or Professor Nutt, who's a leading UK psychopharmacologist, suggests that the evidence is not compelling, I tend to think we need to take a much more structured look at this relationship in future research. Now, what about cannabis being harmful? This is often touted by certain people who I won't mention names. So it's difficult to find accurate statistics about actual deaths that have been attributed to cannabis alone in Australian data sets, because multiple drugs generally have been found in the system of those patients. And alcohol can be thrown in as well. So these are not separated out in these data sets, so it's very hard to get an accurate picture of risk. But we can see that based on changes, obviously, to mental perception, and also considering statistics that are only based on social or recreational use, increased risk of harm potentially exists. But we can always then look at the risk of harm for those things that are, well, legal. So looking at 1998, 19,000 deaths occurred in Australia because of tobacco. So that was a death every 28 minutes. 3.2 million adult Australians in 1995 were being targeted at risk of chronic health disease because of tobacco, which equated at the time to about 23.5% of the entire Australian population. So what about alcohol? That's a pretty sobering tale also. In 2010, there was a paper, Alcohol's Burden of Disease in Australia, and it highlighted that in that year, there were 5,500 deaths attributable to alcohol, with an additional 157,000 hospitalizations in that same year. Now, I don't want you to just consider this as a loss of life, but I also want you to think about this as just a burden to families and suffering, and burden to the healthcare system. It is actually quite staggering. So, can cannabis cause harm? Well, the answer is yes, it can. But comparing currently available statistics that we've got for things like alcohol or tobacco, I do fall back on the classic that I say at many conferences, that it's kind of like comparing a fart to a cyclone. So here we've got statistics from 2012. Teresa's already touched on this. Available statistics, 0 cannabis deaths that were attributed through these data sets. So we'll have a quick look at just how toxic cannabis is. So generally, to determine toxicity, we look at what's called the LD50, the lethal dose 50. So this is defined as the dose that's required to kill half the members of a population after a predetermined time frame. Kind of nasty, I know, but essentially the lower the number that you see here, the increased toxicity. So this being said, what I want you to understand here is that CBD and THC are in their purified forms, so which is obviously not how this appears in the phytochemical profile of the whole plant, and therefore not a very accurate representation of how dangerous cannabis actually is. Now on this slide, which was derived from US statistics, you can see what's called the therapeutic ratio to the effective dose over lethal dose. And cannabis has been rated to be 1 to greater than 20,000. Now I'll elaborate a little bit more on that right now. So just how much whole plant cannabis, this is something that baffled me, would I need to consume to cause death? And so I started digging through the scientific literature and I couldn't find anything. So the Centers of Disease Control in the United States have not recorded any deaths attributable purely to cannabis in their data sets. And the National Cancer Institute suggests that because there are no cannabinoid receptors in the brainstem, which controls respiration, lethal overdoses from cannabis is incredibly unlikely. However, I did find a 1988 Department of Justice DEA brief written by Judge Francis L. Young after expert consultation with pharmacologists, and he stated this, and I quote, "In layman terms, this means that in order to induce death, a marijuana smoker would have to consume 20,000 to 40,000 times as much marijuana as is contained in one marijuana cigarette." National Institute of, or the NIDA supplied marijuana cigarettes weigh approximately 0.9 grams. So a smoker would theoretically have to consume nearly 1,500 pounds of marijuana within about 15 minutes to induce a lethal response. Now, whilst I'm unsure of the scientific validity of that statement, all I can say is this: you have 15 minutes, your time starts now. I wish you the best of luck.
Thank you.
Thanks very much for your time.
Thanks very much, Justin. Do we have any questions?
Get off easy, that's awesome.
Yeah. Okay. Yes, we do have one. Just a moment.
Not specifically related to this, Justin, but I have heard some of the other presentations that you've done. And what I'd like to ask you is how you can get truth in labelling when it comes to cannabis products.
Truth in labelling. So when we start talking about medicinal grade products, it's something that's often touted by some that it can't be achieved, but I would argue that it can, and it's what we call standardisation. Standardisation is a process that's already used in Australia for standardisation of most herbal medicine products. So you could walk into a pharmacy right now and ask to buy some St. John's wort, and it'd be standardised for hypericin or hyperforin. And so that every single time that you get that packet, it will have those predetermined amounts. Where things get a little bit tricky is when you start looking at the complexity of cannabis with its over 700 different phytochemicals, flavonoids and terpenes and 144 cannabinoids, etc. What we've really only focused on is the THC and CBD. Some of the minor cannabinoids are starting to get some interest now as well. So we can standardize products that are botanically derived on marker compounds, those active compounds. But we're not actually testing for all of the other compounds that are in there. And so that's where we talk about the entourage effect. So when you're actually sitting there saying, and this is something that Dedi Mary, who's an Israeli researcher who I've had the chance to speak with on it, classic example they had was over in Israel, of course, they have a much more liberal approach to medicinal cannabis. There were children that were being using cannabis from their doctors for autism. And all of them were being well controlled. All of this was coming from, standardized, tested, validated supply chain. And then suddenly on one day, two patients or their carers called and said, "Is something changed? Because my son, who's usually been very, very well managed with this, started to get a little bit out of control and started being violent towards the carer." And so when Dedi heard about it, he tracked it back down. And he said to the growers, he says, what's changed with this product? And they said, nothing's changed. It's still 1 to 20 THC to CBD. It's a high CBD to low THC ratio. And he says, no, but what else has changed? Oh, well, we've used different genetics. And so what actually happened is that child has been stabilized on a different genetic profile with all of the different chemicals that were actually at different levels, not just the THC and CBD. And then suddenly they bring in a chemovar that's got a different expression of other terpenes and cannabinoids. It had the same ratio, if you will, of 1 to 20, but then it didn't give them the coverage they need. And so what that basically means is that it's not all about THC and CBD, and we really need to understand that there is a lot more involved when it comes to research of that plant. So standardization of labels is going to be an ongoing challenge.
Look, I think you just predominantly answered my question there, but I was wondering if there's any more development in Australia on checking out not just generalized cannabinoid ratios.
Yeah, look, I think when it comes to the current model, when it comes from looking at this from a regulatory context, that they are looking at fixed ratios. Now, ratios in themselves they're not really as meaningful as other things. I mean, a 1-to-1 ratio of THC to CBD, if that concentration of THC and CBD is 3% versus 12%, they're two very different products. So a 1-to-1 or a 1 to 20 doesn't mean so much when you think about it that way, because it's the percentage of concentration that's actually in there that's important as well. So doctors do need to have something that they can try and have some assurance when it comes to reproducible results. Working in research as well, we need to have a reproducible product that we can get reproducible results from research as well. So I think that that's not going to change in a hurry, but botanically derived products are already in Australia. They've been imported, they're able to be prescribed by doctors like Teresa. And I think that what I'm looking forward to is seeing the Australian industry kick in and be able to start growing these products at a much lower cost so that patients won't be stuck with these absolutely insane bills for accessing a product that grows like a weed. Yeah.
So a lot of the people currently trying to access cannabis for medical purposes are quite ill and are vulnerable. So what advice would you give to them in terms of product use, given that the general advice is start on a really low dose, see how you feel, and increase until you get the effect that you want? Would you say that that is reasonable advice?
Look, I've been involved with the mentoring of several doctors in this space over many years, and I think it's a very wise place to start. My main concern is particularly with the patients that are vulnerable, particularly our elderly, and when polypharmacy comes into play. That's my main concern, is because there are some documented interactions within the literature that we need to be mindful of. So particularly what Teresa had talked about earlier, the Cytochrome P450. Now the Cytochrome P450 is in the liver, but it's actually responsible for getting rid of all sorts of drugs and those made within us and those that we take. And what can happen is, particularly with CBD, it can actually inhibit the process by which it's removed from the body. So it's normal time that it takes to get rid of a drug. So this is your pharmaceutical medication. So if you're taking a drug such as a narrow therapeutic index drug that you need to take at the same time every day, because those levels have been established by the doctor after months and months and blood tests, and then suddenly you start taking CBD, and that slows the degradation of that drug down. So that can then potentially cause adverse effects by building it up in blood. That's one of my main concerns, is with people that are vulnerable, that they are understanding that there is the potential for risk if they are on many pharmaceutical medications. But yeah, the go low or start low, go slow is something that's been touted in the United States for many years. And doctors are very comfortable, of course, titrating dose. It doesn't always have to come in a 20 milligram, 40 milligram packet. They use many drugs that they titrate individually for patients. So it's something that they should be comfortable with, and I'm sure they'll learn as they start going to more education courses.
Thank you very much, Justin. I think we'll wind it up there. Once again, please thank Justin Sinclair for
Thanks,
coming
Kat.
and sharing this with us.